Hello to all of you who are here timely. We are right at time, and so I will get it started. Hi, I'm Susan Moore. I am the CEO of Managed Healthcare Resources, and today we are going to talk about the key differences between NCQA and URAC accreditations. Now, some of you come today having experience with one of the accreditors, typically, but not the other one, and you're curious about what it's really like and what the differences are. Maybe it's a self-education you just want to know and maybe help out or upskill yourself for your next journey. And so when we had you register, we offered you the opportunity to submit questions. Most of those questions I will be responding to within the presentation, but there are a few that are very specific that is not covered in this high level differences. And so if you don't get your specific question answered, I apologize for that, but this is really a high level and I will try to cover as many as possible. So if everybody would mute themselves except for me, we'll get going. So I just always like to start these with this is copyrighted and intellectual property, and so you're not to copy it without permission. And if you want to, we'll talk about getting a copy later, but please honor the copyright laws that are in place in the United States. Just a little bit about who's presenting today and what we're doing. I know when I'm viewing webinars, I want to know what the expertise is, what their credentials are. Um, are they sufficient to be able to have the webinar? So I started the company 35 years ago. We just celebrated our 35th anniversary in January. And I surveyed for NCQA from 1996 to 2025 and surveyed all of their products that they have. And we also assist our clients with all of the NCQA products that are available. The URAC expertise, the person who helped me put this together was Leslie Brown Schuler. She just got her doctorate a couple months ago. Leslie was a consultant and an employee of URAC and surveyed for them up until last year and still has lots of contacts. So we originally did this presentation last year and she helped put this together at that time. And she is our URAC point person who works with all of our URAC clients to get them through accreditation successfully and safely on the other side. I think I gave you everything about that. She's worked in quality across multiple organization types. Our vision, which I think is very important, and you gotta know where you're headed so you know that you're gonna get there. And our mission and vision is to empower healthcare organizations to reach their fullest potential through successful accreditation, driving excellence, and raising the bar in healthcare quality standards. We are not box checkers. We are helping you improve the quality of what you do in all of your processes and promoting higher level outcomes that affect the members that you are there to serve. And so it's very important to us to transfer that knowledge to you that we know about what is required in the standards and what the intent is so that you can go forth and conquer and not have an umbilical cord is what I call it to us. I'm a nurse, so I think in medical and human terms. You don't have that umbilical cord to us for every single little question decision. We give you the foundation methodology and the knowledge so that you can make a lot of decisions and just come to us with, after you go through a few accreditation cycles, just use us less each time. And that is what is really fulfilling to us because we want to empower you and transfer that knowledge to you. Just briefly about the history of the accreditors, they both came into existence in 1990 and are 36 years old. NCQA was spawned by the Group Health Association of America, and they wanted HMO quality evaluations. The HMO Act, I believe, was 1973 went into place, but there was still no foundational evaluations across HMO so that you knew if one was a higher quality than the other. So the Group Health Association is where Peggy O'Kane came from, and she just retired December 31st from NCQA and had been there the entire time that NCQA had been in existence. So They wanted evidence-based standards as a foundation so that there would be a trusted independent reviewer of quality and nobody that had any bias or an X grind or anything. They wanted something that was totally hands-off and independent. So URAC came about in existence at the same time. There were this is a same thing that's going on today, the inconsistencies in utilization review. At that point, there was lack of standardization in the type of criteria used, what the processes were used. And so state regulators were going to be involved. And it's the last thing you want is regulators involved in your business. And so URAC worked with a lot of the states to be able to develop the standards, and that then on the side of the state, they would provide a credential so they didn't have to go through state licensure. So the name was in a few years after they were incorporated so that it wasn't specific to utilization review. They changed it to URAC, even though it stands for Utilization Review Accreditation Commission. They wanted to expand the organizations that they accredited to that. So who does get accredited by each of those organizations? So overall health plans with 1 to 4 product lines, behavioral health, case management. You'll see a lot of these. There's a lot of similarities between NCQA and URAC, and there's some differences too. So the approach is similar in applying standards. But for NCQA, the bread and butter is health plans, and I'll get down into some of the data, which I'd never quantified all of that before. NCQA started really with the health plan, the organization side of accreditation, and then went over to the recognition programs where care is being delivered. So the patient-centered medical home, the patient-centered specialty, virtual care delivery, all of those it was kind of sandwiched in there, the member, to get them on the benefit management side and also to get them on where care is rendered. NCQA does additional things that help to support all of their initiatives. They have a lot of data and IT initiatives that support HEDIS and CAPS originally, and then it's expanded to licensing and certification to assure the data is valid. And they're always coming up with measures to try to reflect what's going on in the market, and they retire some measures that don't seem like they've benefited, or you get to a certain height of your how well you are performing, and the incremental increase is not it's going to take a lot of money to get any higher, and so therefore they review these all the time to make sure that they are still relevant and they're where the industry needs to go. So that additional NCQA activities with the recognition programs, I was amazed. 38,000 patient-centered medical homes that NCQA accredits. And the next highest one is the New York State PCMH program. And then you go down to behavioral health integration into practices and patient-centered specialty. Well, it got broke down. Broad accreditation categories for URAC. Whereas NCQA is very integrated and puts all their programs together, and then you have the feeders into the health plan ecosystem. URAC came about with their health plan accreditation some years after NCQA had already taken over the market. And so they have a lot of different programs that are in little fragmented spaces, is what I would call it. They are able to take a topic instead of taking the whole topic, such as with pharmacy. They have 10 programs that are all individual, and there's redundancies in there. I tell you, it drives me when I was working in these. Something that NCQA would have one standard for, URAC would have 5 or 10 standards for that and get at the very same thing that NCQA was. So you can see the different things that URAC has. They really own the pharmacy space, and you can see there's all these little niches that they go through to accredit different entities. So really you can get very, very detailed and very niche-y with something like that. They have different accreditations for patient care management. You'll see they separated health from work comp and disease and case management. You can get health context in our accreditation. And there's a lot of crossover in programs too. So you'll see something in one category that they have made, and it'll be in 2 or 3 categories, just the way that they operate. Oops. So here's their digital space. 11 health plans. What I want to bring your attention to is that they separate out commercial Medicaid and Medicaid with LTSS, health plan with LTSS, marketplace, and Medicare. Now, for NCQA, you go in and you say, I want health plan accreditation. Well, how many product lines do you want to accredit? Okay, then you have those product lines. You submit it under one application, and then you attach those documents to that. For URAC, you have to buy those separate accreditations. They have their separate tools. And so there's no real, right now, synergy between, oh, you attach this to this one standard. The same standard affects another product line, and maybe you've added all of those product lines together, such as for timeliness, for decision making. You have a table in there that will do this for marketplace, will do this for Medicare, this for commercial, and you use the same policy. Well, under the NCQA ecosystem, you just attach it once. Under URAC, you'd attach it twice. It's a lot more labor intensive, shall we say. They're the only ones that monitor mental health and substance use disorder parity. That is a national and state requirement. And they have the parity software with that everybody puts the information in. And so that's something that that's unique to them that NCQA and others do not have. So let's look at product design. I told you that health plan was comprehensive and that URAC had them all in separate tools. For NCQA, as you know, HEDIS and CAPS is really important and provides 50% of the score in health plan accreditation. There is no, even though URAC will allow you to use HEDIS results in any of their outcome-based performance measurements, it's not required. And they're trying to move to more outcomes-based, but they're not quite there yet. They're nowhere near where NCQA is. Behavioral health is a separate accreditation for NCQA. It includes and CM, but when you look at it under the URAC space, there are 4 different programs plus community health workers. So you could, instead of just one for NCQA, it would be 4. You decide which one you want that's specific to the area and the little niche that you want to look at. Case management is in PHM 5 under the health plan standards, along with standalone, and it's basically standalone for URAC. Because health plan and standalone, and then for URAC it's integrated, or you can do it standalone, and there's a separate one for workers' compensation, apart from the medical. Here's where I had never looked at this before to see how many were accredited under each. And it was kind of surprising that there are some of these that have 0 accredited for URAC, and they have all of these accreditations that they have to keep up the standards for. And that's probably why they don't update them as much as NCQA does. And I've got another slide that addresses that. Health plan is updated every single year, either tweaking the previous year's major changes or the year's major changes. And the products are on different timelines. They're published in November for NCQA, and then they are applicable the next July 1. Typically, these are, when they make changes, they're because the health plan requirements have changed. And so since it is a health plan-based organization, and in that ecosystem, everything does trickle down to all of the other lines of other products. Now, what in the last few years, what NCQA has done finally is to synchronize all of the accreditations. It used to be that if you when NCQA changed their scoring from met, partially met, not met, to that from 100, 80%, 50, 20%, and 0, they did that for health plan and maybe 1 or 2 other entities. But as a surveyor, you're going in and saying, oh my goodness, this is so different. And so you always had to keep in mind the differences between what the health plan and some of the other ones that had everything moved down to it, to what you're looking at. Behavioral health was a big one because the standards numbers for QI1 or whatever were not the same between health plan and behavioral health. So I always had to crosswalk that for we consultants so that everybody knew here was how you met it for health plan, and then this is how where it's found for the behavioral health and what the differences were in there. So they've done a great job in the last year in bringing those all together and all comprehensive, but their process is really extensive to make any of those changes. But you can see here that NCQA really owns the health plan space for accreditation compared to URAC over here. And of course, NCQA started about 4 or 5 years ago trying to promulgate the specialty pharmacy standards. I don't know why, because as you see, URAC owns that space. They've been around with the pharmacy forever when NCQA had nothing but the one pharmacy standard and the health plan standards, or the entity could undergo accreditation and get some automatic credit for the health plans by doing that, and which is really good for denials and appeals on these must-pass standards. That was really a plus. But URAC owns a space, and they've got all different areas that you can see for those little niche products. And NCQA owns the behavioral health space, really, except for the parity. That's different. So I was surprised at how many for NCQA have case management. Even though I looked down the directory all the time, I was surprised at the scope and breadth of that. Only 50 for URAC. And you see this 121, and over for URAC, it's 151. And that connects well back to those state mandates. There are organizations that have both for NCQA and for URAC. And the reason is that is because they typically have undergone health plan accreditation. They have different units, like a standalone TPA, that they want to get automatic credit when the health plan submits. And so they will have that, and they will also for NCQA and also for URAC, so that they meet both of the needs. And frankly, utilization management is a cheaper product than health plan. And so if you're going to do double duty, that's one of the ones that you want to do it for. What I didn't realize until I did the numbers, and URAC makes it very difficult to find the numbers. You have to go down into every single accreditation and get the count for that. But NCQA really owns the health equity, health outcome space. For you that are familiar with NCQA, as of July 1, just in another week, the health equity is renamed into health outcomes, and health equity plus is renamed into community focused care. So 364 entities are accredited by NCQA for that area, and only 3 for URAC. Credentialing, another must-pass standard, another area that when there's penetration into the physician market with a lot of the recognition, they also see that to get automatic credit and to get into the health plan networks faster, they will get in faster if they are NCQA accredited in credentialing. And the stakes are high because they're must-pass requirements. So you see there's a big disparity there. And then population health, 40 for NCQA, 1 for the employer-based health. Just so you know, not all the products were displayed. I took what was either a lot of organizations that were accredited on one side and then compare them with the other accreditor and vice versa, so that you had an idea of that. So a lot of these standards, as you know, when I've said that NCQA's focus is health plans, and that's their penetration in the market, they also, to feed into that, have the standalone products. So credentialing, population health network management, and some of the for pharmacy, and then of course health outcomes. Those are all standalone products along with being integrated with the health plan products. Now, NCQA came out with virtual care recognition last year, and URAC has full telehealth accreditation and supports certification. So you see there's a lot of different things that are standalone here for URAC. Market recognition. Now, When I talk to people who have had both or worked in organizations who have had both accreditations, I ask them who they think is the most difficult or highest quality. I don't want to enter my bias, even though, of course, as I surveyed for NCQA for 29 years, I did have a bias also with working with the URAC requirements and seeing how they functioned, what their processes were. I considered them easier and NCQA more difficult. NCQA more rigorous and higher quality due to look back periods. Now, what's funny is that there are some of these requirements that each accreditor is picking up from the other one, such as URAC has gone to look back periods now, where they never used to before. They are this is really important, process and outcomes focus for NCQA. I don't know if you're familiar with the quality rubric that, his name escapes me right now, set up in structure, process, and outcome. And those are the three areas in healthcare that you can look at and you can tweak and change. And if your structure is not promoting quality, it doesn't matter what process you have, your outcome is going to be not quality. And so NCQA has some structure, but more process and outcomes focus. And URAC is structure and process focus. They look at, even though NCQA looks at committees, URAC looks at training, and a lot of these other ones, it has a lot of requirements about that. I'm going to jump back here, and sorry for jumping, but they kind of go together. They're comprehensive standards, like I mentioned for NCQA, and smaller products limited in scope. The big difference is that who surveys for each of the entities. URAC has W-2 employees that are all nurses that do all of their surveys, except for pharmacy, and they bring pharmacists in for that. For NCQA, except for the employees that work in different areas of accreditation who have to do 1 or 2 surveys a year, everybody else are contractors that work in managed care mostly, that come to the position of surveying with eyes knowing what managed care is and how it operates. And I've been on site and listened to a lot of the reviewers, that's what URAC calls them, and see that their depth in managed care isn't always the same. And so it seems like they're kind of talking at cross purposes with the health plan entity staff. Both of them the same year developed a web-based tool. For NCQA, it's IRT, and for URAC, it's AccreditNet. Punitive is what a lot of people think that NCQA is, and I've heard URAC reviewers make those comments about the other accreditor is more punitive, but we take an educational approach. And what that is during that whole process, they're educating you on the standards, which hopefully you would have known the standards pretty much before you ever went for accreditation, because there's a lot of work that they have to do and being consultative. NCQA, the surveyor management, specifically prohibits the surveyors from being consultative. They're supposed to guide the staff into what information is required. And there's a fine line there a lot of times when the staff is really pushing you to say, will this meet it? Will that meet it? And what does this really mean? Where we're not supposed to be, I say it's only been a year since I've been out, consultative in our approach to them, but it really does most of the time get down to that when typically people have not used a consultant to help them to parse through the standards and really understand the depth of what the standards mean and where the roadblocks are. There are 27 states that require NCQA for Medicaid, and 7 others, except health plan accreditation, is meeting the broad requirements of the state. You can see I listed all of the states that either accept either accreditor or allow both accreditor, or there's a few of them that are very specific to which one they require. Now, because it's a mandate for several states, so this was health plans, but this is specifically for process. And here's all of the ones that require URAC, and then others that will accept URAC in lieu of state certification. And then when you operate in several states under a license, URAC really makes the best sense for operational and legal efficiency. I mentioned that standard cycle is July 1 every year for the health plans. There are every other year they do massive overhauls, and then on the opposite years they tweak them to make sure they mean what they want it to mean, because during the year they get policy questions and they feed back that information back into what does the standard say? Did we need to make it more specific? Did we need to add information into the explanation so that people understand what we really want and don't get excess material on a survey that doesn't belong there? So they look at the standards and where the most missed standards are, along with the policy changes, policy questions. Now, for URAC, you don't know. Right now, they're on 8.2 or 3. They don't have a set schedule for coming out. According to my understanding and talking to some of the people there, they wait until there's a kind of enough substance to take the time to make the changes in the standards and any regulatory changes in between. Even though NCQA has its fingers on the pulse, I say CMS sneezes and NCQA says, bless you. URAC is really tuned into regulatory changes and compliance type areas, as opposed to NCQA, who's really into continuous quality improvement and has said in surveyor trainings, we are not here to be compliance with regulators or regulation oversight. We're here to assess quality. But URAC is a lot more tuned into regulatory, which is understandable from the way that they started. It was all regulatory. What really gets me is standards access. It irritates me. NCQA has full disclosure. Anybody wants to go in and see what their standards are, you go in and you purchase them for the amount of licenses you need. And so you know if you are going to go for that accreditation, you know what the requirements are before you put your money down for the application and take the plunge. For URAC, they only give you or you pay for standards at a glance. The detailed standards, such as what NCQA side is the factors and the STEM and the explanation, are not given to you after you buy the standards at a glance, only when you apply. I think I know why that would be, but I'll try not to be that skeptical, but it's probably for getting people hooked in. So as consultants, our clients typically they're allowed to give their standards to us that have all the meat in them so that we can help them to meet all of URAC's requirements as we go. The accreditation's 3 years for both. There's a certification that's still hanging around for one product, and that is the what used to be the CBL product. That's now a credentialing certification. Now, NCQA, if you say you get up closer to the survey and say, my bad, we're never going to be able to get ready for NCQA in 2 months. Finally, staff and leadership finally gets religion and thinks, we were a lot more aggressive than we should have been. And when we could be ready, there's a lot more requirements. And so because each of the accreditors does a lot of work in the background for setting up surveyors and doing all their planning that they have to do, you have to ask for an extension. Now, if you've been accredited before, they don't want it to extend beyond when your renewal date would be, when the final accreditation went into place from your previous one. If you're an initial one, they will sometimes give you an extension if it's far enough in the future, that they haven't already assigned surveyors and they haven't done all the prep work. Now, for you get closer, you're going to have to pay a fee, and that's just what it is. So if you think it's a possibility you need to change your date, do it well enough in advance for NCQA, and you may be exempt from having to pay this, a pricey extension fee, because they want it to be a deterrent to changing that. They want you to get on that path and stay on that path. So for URAC, they will give up to 2 extensions with no fees, and the third extension has a fee. The timeline is not important on that side. I already covered the IRT and the AccreditNet tool. Just some more comparisons. NCQA calls what you would call policies and procedures a documented process, and it needs to be very, very specific with timeframes, who, what, where, when, and how, and SOPs that don't have all those details in it, or timelines that don't have that because of the look back period. You need to have dates about when it was effective. And so you need to have that along with who is doing it. So there's accountability in whatever process you're going into. URAC calls it a policy and procedure. For NCQA, there's no requirements about how frequently it has to be updated. URAC used to be you had to update it every year, but now it's every 36 months. You shouldn't go beyond that without getting a ding on their policy and procedure standard. Of course, you need to put revision dates, distribution, communication dates, and effective within those 36 months period. And they will ding you for that. They have a policy on policies, and you have to have a policy on policies too. That look back period that NCQA has had for quite a while, and URAC just started integrating that in the last 4 to 5 years. For initial, it used to be just for health plan, they would allow interim accreditation. That started with when the Affordable Care Act went into place, and they wanted to have a glide path, what they called it, to get people into accreditation expeditiously and not have this onerous look back period, which they used to have a longer look back period for new health plans. Because during the Affordable Care Act, many health plans that had never been accredited, could have been considered new, were needing to come for accreditation because that was the requirement by the regs. So NCQA instituted a 6-month look back period for interim accreditations at that point. So that gave you 6 months. You could have wet ink and you didn't have to implement everything, which they've changed some of those now with delegation and credentialing, but you didn't have to have everything in place and demonstrate that it had been in place for a long time. And so now, after the first 6 months, well, they have integrated that into their other accreditations so that there is a interim for others to be able to bring them into the fold and get them down on the accreditation pathway and probably not lose them to different accreditors. The renewal look back period is 2 years for non-file review. And undergoing a file review for everything except credentialing, there's only a 1-year look back period. And that's why we do file reviews for clients 18 months prior to the look back period or prior to their submission. So they have 6 months to fix what is broken and to train and sustain that change during that time. Credentialing file review is ongoing. And that is really important because they are the backbone of your organization. Who the members see is critically important. So you can't let that lapse. You have to make sure that on an ongoing basis, there's no broken accreditation cycle and that you can put that from the time they get in the network all the way to the survey. Now, URAC has look back periods, and it is really survey to survey for standards and files. Now, if something changes with the standards during that time, they will modify that look back period to accommodate that. Or if there were some specific circumstances, they can also modify it, such as merger and acquisition. However, it's survey to survey for URAC. Now, another thing that people that had both URAC and NCQA got tripped up on is the nomenclature specifically for providers versus practitioners. So URAC providers meant everybody. For NCQA, providers are those people who are those bricks and mortar, like hospitals, home healthcare, surgery centers, and etc. Practitioners are what I call warm bodies. I think that helps to distinguish that. So anybody who is providing care as an individual is a provider, and on the NCQA side, providers are the bricks and mortar or the facilities. So definitions are different. NCQA has some very strict annual requirements. You have to do it year to year. So if you have a 2-year look back period, that means 2 years of, let's say, analysis. That's where we typically see it, or distribution, that you have to do it within that 12-month period, but they do give you a 2-month grace period, only on one side, only on the plus side. If you're trying to fix something and you do it in less than 12 months because you finally realized it wasn't compliant, you needed to get it compliant, and it's only 10 months since the last one, it will not work. You are supposed to get dinged for that because you should not be catching up. You should be having quality on an ongoing basis. Now, there are no strict and specific annual requirements for URAC, so that's where it's a lot easier. And I'll tell you, I dinged a lot of organizations for this annual requirement. We do as a consultant when we're doing gap analyses too, that this is really a critical area you need to keep up for NCQA that is not critical for URAC, and that's why it's considered a little bit easier. Now, another major thing that's different with URAC and NCQA is that NCQA, if there is a stricter state requirement, you don't have to follow that for the survey. Now you do for your compliance, but for the survey, we only hold you to requirement that's in the standards. So everybody is evaluated on that. And there's no differences. Now, if there, tell you one of the reasons that people get really caught up in something is they say, well, the state doesn't require it, so I don't have to do that. That's typically Medicaid organizations that tell us that. And it's like, well, confirm on me. No, it's a standard. You have to follow it unless you're strictly prohibited by the state from doing something like a time frame. And those happen. I know Pennsylvania has some of those and some other states. But you have to provide the contract that says you are prohibited. Absent that, you have to go to the state regulators and say, would you issue me a letter? This is my fallback position. Could you issue a letter that we're not allowed to do this? Now, if you know state regulators, you know that they're not really happy about signing their name to something that goes through a whole lot of departments before they can ever, including legal, before they can ever submit that to you. So unless you're strictly prohibited, you have to follow the NCQA requirement. For URAC, if the state requires a more stringent requirement, or you say, hey, we want to be special, we want to follow a stricter rule, you are going to be held to that stricter rule that's in your policies and procedures or the state requirement if it's stricter. NCQA says, if your state requirement's stricter, you're automatically going to meet our requirements, right? True. So you still have to meet that for your process. If you want to know as an individual how something would be surveyed, or as a health plan, you can submit on NCQA's policy clarification support a question, and it is then connected to you if you've put it under your health plans or other organization. They connect those. I didn't think they always did, but they do. I found on the surveyor side, they went back and looked at all those questions by the organization, and it was a deer. They shot themselves in the foot. So we, as consultants, will always recommend that because we know the intricacies of the questions and the standards, and we know that if it's unfavorable, your response, and you don't want that connected to you, that we can send that in for you, and then we tell you to keep it in your back pocket if you need to, or to support you in what you're bringing forward, that will give you a good support. For URAC, you can't do that. Nobody is able to. I couldn't go in and submit a question on a client's behalf. It's whoever is assigned on the URAC side, the reviewer. The questions are answered by that reviewer, so it's kept in their own little bubble for that whole survey. So, it's kind of risky to ask some questions about that because it's all kept in that documentation. If you have not been assigned to a reviewer after you have signed up for a survey, then they have a client relationship manager or interpretations inquiry system, but that's only for those who are inside the application process. So one of the most frequently asked questions for these accreditations is, how long is it going to take? I know you want it yesterday, and I don't have a magic wand that I can get you ready yesterday. So now, if you look at interim accreditations where it's a subset of all the standards in that interim, and they don't have to be implemented, a reasonable time is 3 to 6 months. And it depends on the complexity of your delegation, the software you're using. Some orgs don't even have software selected yet, and they're coming for their accreditation. We know, it takes 3 to 6 months just to get software evaluated and in place and trained. And so that's going to take longer. And some haven't even looked for a consultant until after they're already have applied and have very little time left. And then it's, oh dear, I think we need help. And this happened to us just recently. To be comfortable takes 9 to 12 months, but there's a balance here. If you set the time frame out too long, people don't feel the pressure. You do it too short, people get demoralized, and you're on that track once you start, unless you get an extension. So for NCQA, I would say 6 months for an interim accreditation, but you've got to be full speed ahead. This is a real culture change. That's the long and short of it, the way you do business, and people have to get retrained and know what they're doing. Now, for URAC, first-time accreditations for any product can be done in 3 months with the same caveats as NCQA. Because there's a heavier emphasis on process as opposed to a structure and process instead of outcomes, you can sit at the desk and develop all these things. The thing is, what URAC has that NCQA gave up in, I think, 1999 is an interview process. So they are going to be very specific and very detailed on what they're asking and the interviews, and that's right in their standards, not standards at a glance, but their full standards guys about what they're going to ask you. And if there's a discrepancy between what you say in the process and what's actually occurring, you're going to get dinged. So yeah, you can write in your cubicle and write all the documentation that is going to be needed for your accreditation, with that strong caveat that you better be doing what you say you're doing, because you're going to be held to that. So coming down here to getting to the end of this, all but file review is done offsite for both. More for NCQA than URAC. URAC still goes on site for file review. We'll do some final documentation review if the organization will not provide that, such as committee minutes that their legal department won't let them share with the accreditor. Then they'll have to review those on site. But predominantly, they're both doing as much as possible off-site, and URAC is still coming on site with their file review. The difference here is that this is a once and done for NCQA. You have to submit everything that was in existence that applies to that standard at the time of the survey. But I'll go through just a little bit. Then we tell the client there's outstanding issues. Here's the gap, and this is what we need. Send it to the organization for review, and there's a conference call to clarify what is needed, and resubmission of documents that were present at the time of submission. You cannot modify anything, and that goes along with the look back period and the importance. Now, for URAC, you can develop a document, a process, change things because it's not compliant, and they're not going to proceed until the score is 100%. So they're not going to go down the path of file review if you're not even passing the off-site requirements. So for health plan and behavioral health, they have 2+ surveyors for file review and 1 for smaller products. After the conference call, you have 3 additional days to submit any documents that were in place at the time of your original submission. And here URAC goes through round 1 and a call and verifying what needs to be provided, and then call 2 and on until you finally get a passing. But the only thing is, there are times where organizations can't pass because they just can't get it all together, and therefore they will at some point issue a denial. But they have 2 reviewers on site for 1 day. And external consultants are not allowed for either one of the accreditors, unless they are one of those organizations that had consultant review most everything, or they had a major overturn of staff where current staff, the consultant, has been there longer than staff has. And we've actually been in those circumstances where we've gone through 3 accreditation surveys and there wasn't anybody in the health plan that had even had one yet. That's what I call the revolving door. So at that point, you have to both accreditors see the benefit of having somebody that's going to augment to make sure the survey process goes better. I'm not going to go through iterator reliability. Everybody knows there's issues with that. Big difference is file review. There's a universe of files that you submit for those areas that require file review at the time of your submission. Now, the big difference is that URAC doesn't pick those out. NCQA picks them out, the random sample out 2 weeks before. They will get the files, URAC will, 2 weeks before the validation audit on site, and they will give you 5 to 7 days before file review to pull those files out. I'm not going to go through this. There's a little different process afterwards. The committee reviewers, it goes to the Review Oversight Committee. There is a major difference in who is on the committees between the two accreditors. These are typically physician surveyors by NCQA that do survey review and appeals, and organizations are provided a listing of all of the potential ROC members so they can identify a conflict of interest. For URAC, there is no transparency on that. Nobody knows if one of their competitors is on the oversight committee that makes the final decision. And so there's no conflict of interest disclosed to the organization. I've verified that a few times. There's no monitoring between cycles with NCQA. You will have that with a mid-cycle with URAC for specific ones, and typically what those focus on are ones that the organization was getting accredited on the thread, and they didn't have a long history of being able to meet the standard. And so they want to go back in and make sure that these are still in place. They haven't let them drop, and that they are going to review that. So they review all the mandatory standards and any standard that's weighted 8, which is the biggest, the most point value. NCQA has a merger and acquisition survey if there are material changes. That could happen with URAC, even if it's a change of an office location, which is interesting. Okay, I'm not going to go through this except automatic credit. This is one of the questions. I think this is one of the major strengths that NCQA has. As I told you, it's all in the health plan ecosystem. So all those standalone products roll up. When you delegate activities that are your responsibility to one of those external entities, like a population health organization, credentialing, physician organization, whatever, if it's in a delegation agreement and they have their accreditation as of the submission date by the health plan, there will be automatic credit. That's like a magic wand. It doesn't matter if they're perfect. They will be deemed perfect because they've gone through the NCQA oversight process. For URAC, there is no automatic credit given unless there is a URAC accredited organization that handles the appeal portion of the case. And that's limited to the physician's, the provider's credentials. Just they don't have to be validated because they already have been validated during a survey. So to me, that is huge because that is something that reduces the oversight burden considerably and also promotes NCQA's brand when you do that. So to me, that's a huge one, especially when you're dealing with must-pass standards on file review because the risk is high. So here's some decision staffing resources. How long you've been in business. If you've been in business longer, you'll typically have more documentation to support you, but not necessarily. Are you a typical health plan versus other types of entities? Do you have regulatory accreditation requirements where you have to choose one or the other over the other? Is there complexity that will impact staff that is harder with NCQA than it is with URAC? The degree of confidence you have in the quality of work that you put out. And to me, again, here, automatic credit capabilities and what employer-based accreditation requirements are. Excuse me. There we go. When URAC makes sense, state regs, of course, require URAC. You're more regulatory focused. As you might remember, I said they're more compliance oriented rather than quality, structure, and process, especially if you need it in a short time because you can do URAC accreditation faster as long as you have enough people to write everything, with the look back periods for NCQA, not so much. If you are going after a specific accreditation that NCQA doesn't have, like PBM or dental plan or contact center, you want to go for one that URAC has instead of NCQA. Now there is, if you go down to 5 there, if you're new to the industry, you want to demonstrate operational excellence, but there's no specific product for that. There is a healthcare management certification that will give your contracting entities a little confidence that you've had some standards compared to your organization and you were certified. I've had, and talking to different people on the URAC side, there is a first time accreditation URAC better fit because there's a forgiveness a lot of time on the first review. NCQA is, you have the standards, you know what the look back periods are, you make your application within the time frame you think you're going to meet it, and therefore we don't forgive that because we need to have consistency and iterator reliability, and that everybody has had to follow the same requirements when they have that accreditation. So if you have a state Medicaid or exchange program and recognitions required, NCQA is your better bet. 85% of the health plans who sought accreditation after the Affordable Care Act went into place followed NCQA instead of URAC. Your organization's a health plan, provider group, specialty organization that NCQA has a product for, or your organization's a feeder into the NCQA health plan ecosystem with the automatic credit. Now, there are several companies that hold both NCQA and URAC. I didn't go do an exhaustive review of those. Typically, because of the cost, most organizations won't have that. But if they're required by states to have accreditation and their health plan has followed the NCQA health plan accreditation, so they want to keep, and they have let's say a TPA, standalone TPA. They want to have both accreditations for both because of the specific needs, and it is not as expensive as, let's say, having health plan accreditation with both of them, which would drive you nuts and is unnecessary and inefficient. Now, I just wanted to give you the official websites for the report cards. Here, you can go in at any time and find that for NCQA and URAC. URAC just doesn't make it easy. I'm going to show you. For NCQA, you go under the right one and go look it up. And it will tell you, you click on whatever type and it'll only bring up those. So there's a lot of filters. For URAC, you go into urac.org, you click on directory, and then if they're accredited versus certified, you search by either one of those. This is usually your better bet. You'll get more on that one. And then you go in, and what I do if I don't have a specific org that I'm looking up, you go in and select a program. If you don't need the state, you don't have to do that. And then all of the programs will drop down here and you can click on it and then it will tell you how many are accredited in each of those areas. So you see case management, there were 55 at that time that had URAC accreditation for case management. So just to let you know, as I mentioned, we do consulting with gap analysis and mitigation. As much as we want to promote organizations to own and have skin in the game, there are a lot of times that you don't know enough to write everything that needs to be done. So our rule of thumb is if you can't understand it after it's taken 2 passes for training you on what the standard means and you're still struggling, we will coach, model, mentor you, write documents, but we still want you to do it on a long-term basis so that you understand it, because there's really not enough money in the system to pay consulting costs to do all of that. You need to be able to do that and to understand how everything that you do on a daily basis feeds into the standards so that you understand if you remove something from a document or you change a process, whether it's going to affect your accreditation or not. And not just the primary person who's responsible for accreditation, but the staff that work under it so they know the intent, they understand why they're doing things. Now, we do have an extensive library for NCQA and blogs, and we are adding to our URAC library and blogs each month. We have 9 blogs so far on URAC, and we have another one I think is being published this week, and we're doing 1 or 2 blogs on URAC a month. So you can go on our website at managehealthcareresources.com and look at the drop downs there and see their blogs specific there. And then there are categories on the right side when you get into the blogs that are specific to whatever standard or area that you're wanting. I think the one coming out this week is the NCQA CAP process. As much as nobody likes to go through a corrective action plan, you need to know what you're going to encounter when you do. And we do have past complimentary trainings on our website. So we're not going to share the slides today, but everybody, if you're not a client and book a discovery call, we'll be glad to share them, because at that point, you're probably trying to figure out, do we need to follow NCQA or URAC and what would make the most sense? So you can do that. Contact us on our website, or we have an email at info@managedhealthcareresources.com. And everybody registered is going to get the recording link and the request to complete a couple question survey. And I know everybody has survey fatigue. I got 3 today already. It just gets to be rather annoying, but it only take a few minutes of your time. And we really do want that feedback to know how we can improve, because we are a continuous quality improvement organization and want to know how we can improve. I did develop a selection, how to select using questions on should you go with NCQA or URAC. It is not quite ready. It's going to be a very low price. We'll be communicating that with you about what that is and how you can get that in case you are somebody who's actively looking. Do we want to change accreditors? Do we want to choose one of these over the other? It will help give you a little more data. I like data and something concrete. It's a woo, this is what I feel. This is what's concrete, and this is the one that we should be choosing. So thank you for your time. I know time is of the essence for everybody. Everybody's working with a limited staff. There's so many people being laid off, and AI just can't take the place of everybody. So I appreciate the time that you spent to be invested in our webinar today. And if you have a question that didn't get answered on the webinar, we did have that info@managedhealthcareresources.com that you can send it in, and I will be glad to answer those questions. It just can't take the place of consulting. If you're wanting to have consultative advice on different things, I can't do that because I don't have an agreement with you, but I can give you some general information that may help point you in a direction or not. So thank you very much. I hope you have a great rest of the day, and we're only a week out from our 250th anniversary as a nation. I hope you have plans to celebrate that, because those don't come around every day. Take care, guys.